Inherited bleeding disorders. Pathophysiology. NB. Bleeding involves more than just clotting factors. Vasoconstriction occurs following vessel injury. Platelets adhere to damaged vessels because von Willebrand factor, VWF, acts as an anchor. Further platelet aggregation occurs to reduce blood loss, primary hemostasis, and the activated platelet surface acts as a nidus for the activation of clotting factors, secondary hemostasis. Platelets and VWF are as important in bleeding as clotting factors, Fig 35. Most clotting factors are produced in the liver, but VWF derives from endothelium. The division into an intrinsic system, activated by contact, and an extrinsic system, activated by tissue factor and factor 7A, always seemed somewhat artificial. Trauma produces both triggers. The division was useful in explaining the differences between the laboratory prothrombin time, extrinsic system, and activated partial thromboplastin time, APTT, intrinsic system. The whole importance of the intrinsic system in vivo was in question because factor 7 does not produce severe clinical bleeding when deficient. Factor 7 deficiency, however, causes severe bleeding despite a normal intrinsic system. In recent years, the clotting pathway has been reviewed in an attempt to provide a better explanation for in vivo activity. Tissue damage produces tissue factor, which binds and activates factor 7. Activated factor 7 goes on to activate factor 10 and factor 9. The cascade is amplified through the intrinsic system, and thrombin and fibrin are produced within the clot. The production of thrombin, 2A, itself activates factors 5, 8, and 11 to amplify the cascade, Fig 36. Thrombin generation is central to the clotting cascade model. This revised hypothesis puts greater emphasis on those factors which through their absence produce profound bleeding. The cascade is regulated in a number of ways. A tissue factor pathway inhibitor acts to inhibit excess factor 9 and 10 formation. In addition, plasminogen, protein C, protein S, and antithrombin 3 are activated to limit excess clot formation, Fig 36. Epidemiology. Each inherited clotting factor abnormality has a variety of possible genetic abnormalities underlying it. It is not surprising that there are a variety of clinical phenotypes. Von Willebrand's disease, VWD, occurs in 1% of the population and is usually very mild, autosomal dominant and affecting chromosome 12. Factor 8 deficiency is X-linked and occurs in 100 per 1 million population. Hemophilia A is caused by a variety of different types of mutation within the factor 8 gene, and about 30% of these are spontaneous mutations rather than inherited. Factor 9 deficiency is also X-linked, hemophilia B, and occurs in 20 per 1 million population. It is usually associated with deletion within the factor 9 gene. Clinical presentation. A thorough bleeding history is essential when considering whether a patient has a congenital bleeding diathesis. Carefully document all episodes of potential hemostatic stress, e.g. surgery, dental extractions, periods, and childbirth, in the patient's life. A patient who describes excessive blood loss after every hemostatic stress is much more likely to have a congenital bleeding disorder than an individual who reports bleeding problems only in recent years, or excessive blood loss on some occasions but has demonstrated good clotting on others. Also ask about family members, as many bleeding disorders are inherited. Von Willebrand's disease. The majority of VWD is mild. Many patients are unaware that they have mild VWD and are labeled as easy bruisers or bleeders without explanation. Many women with mild VWD have abnormally heavy periods that they do not seem to regard as atypical, perhaps because their mothers or sisters, who also have VWD, have similarly heavy periods, so female members of the family believe it to be normal. Equally, many doctors are unfamiliar with the diagnosis of VWD and how common it is, and patients are not infrequently seen in a hematology clinic later rather than sooner. Unfortunately, it is not unusual to diagnose women with mild VWD in the hematology clinic only after they have had a hysterectomy for menorrhagia. Other than heavy periods, mild VWD sufferers commonly present with bleeding following tooth extraction, nosebleeds or easy bruising. Moderate deficiencies will be associated with more substantial blood loss related to trauma or surgery, but rarely hemarthrosis. Only 1% of patients with VWD have symptoms severe enough to mimic those of hemophilia A or B. Hemophilia. 2/3 of boys with severe hemophilia A and B, where less than 1% of the normal level of factor 8 or 9 is present, are diagnosed at birth when the boy is born to a known or suspected carrier. The remaining cases occur as a result of a new mutation and present in childhood when the baby begins to crawl and falls, or with the eruption of dentition. Traumatic and spontaneous joint and muscle bleeds are the most frequent manifestation in children and young adults with severe hemophilia. Historically, joint damage has often progressed to a deforming arthropathy, Fig. 37. The aim of modern treatment is to prevent deforming arthropathy by the use of regular prophylactic recombinant clotting factor treatment, physiotherapy, and education about how to avoid bleeds and the need for early treatment. Some patients have a milder clinical phenotype relating to higher factor levels. 1.5% of normal levels produces moderate hemophilia, while 6.49% of normal levels produces mild hemophilia. These boys present following trauma or surgery, e.g. tonsillectomy, with excessive blood loss. Generally, individuals with mild and moderate hemophilia require treatment on demand, i.e. in response to bleeding or in preparation for surgery. Cerebral hemorrhage was the major killer of hemophiliacs before the advent of AIDS. Extensive use of blood products has led to a high incidence of hepatitis B and C in addition to HIV amongst the hemophiliac population. Furthermore, many patients alive today have been exposed to the prion responsible for variant Creutzfeldt-Jakob disease, although the clinical impact of this is presently unknown. The availability of a recombinant factor now free of all human-derived components should hopefully ensure that blood product-transmitted infections for children born with hemophilia will no longer be a major concern. Platelet disorders. Bernard-Soulier and Glanzmann's disease result in defective platelet function and quantity. They are rare, but can cause severe bleeding in children. The problem principally concerns primary hemostasis, and patients suffer with mucosal type bleeding, e.g. nosebleeds, mouth bleeds and menorrhagia. Investigations. Clotting tests. A clotting screen may reveal a slightly prolonged APTT in VWD, hemophilia A or hemophilia B. Specific factor assays are required for diagnosis. Deficiency of factor 8 is found in hemophilia A and VWD. Deficiency of factor 9 is found in hemophilia B. In VWD, VWF antigen is low, but normal in hemophilia A, and its function as measured by the Risto-Seton cofactor assay is reduced, but is normal in hemophilia A. Blood count. FBC and blood film will give information about platelet count and morphological abnormalities. Platelet function tests using a number of different stimuli can reveal patterns of defective function. Treatment. Only treat VWD and hemophilia after discussion with a senior hematologist and/or a hemophilia center. The principles of treatment are discussed below. Von Willebrandt's disease. 1-deamino-8-D-arginine vasopressin, DDAVP, can stimulate VWF release from endothelium when given by either intravenous or intranasal routes. For more significant bleeds or prior to major surgery, DDAVP should be infused over half an hour at a concentration of 0.4 g/kg. This can be repeated 2 or 3 times to cover surgery. It should increase factor levels approximately 3-fold over the baseline. Tranexamic acid is an antifibrinolytic drug and can be used to increase clot stability. Occasionally, in more severely affected patients or for prolonged and major hemorrhage in less severely affected patients, factor VIII concentrates containing VWF may be required. This product is derived from plasma and carries potential risks of transfusion-transmitted disease. Hemophilia. Generally, severe hemophiliacs require prophylactic treatment with recombinant clotting factor to prevent bleeding. About 1/3 of boys with severe hemophilia A develop an inhibitor to factor VIII after factor VIII treatment. This compounds the bleeding further and complicates therapy. Treatment of hemophilia and patients with inhibitors should be directed from a specialist center. Patients with mild or moderate deficiencies of factor VIII or IX will need infusions of these concentrates for bleeding episodes. Recombinant factors are now used routinely for all patients. In the milder forms of hemophilia A, DDAVP infusions may stimulate factor levels as with VWD. Prognosis. The life expectancy for patients with hemophilia A and B should now be well into middle age in the era of blood product-free concentrates.